Good morning, everyone. This is Raul Amin. I am the Psychiatry Residency Program Director at Walter Reed. And today's topic is focusing on managing depression and anxiety in primary care setting. And we put in our title, "In a Hurry." So I happen to be a graduate of the combined internal medicine and psychiatry program. And in my primary care practice, I know that I don't really have as much time as I do when I'm wearing my psychiatry hat or psychiatrist hat on. So it is something that is near and dear to my heart personally, because I see so many patients in the primary care setting in my internal medicine clinic that have significant psychiatric needs, but those needs are not necessarily met, either because the individual patient isn't diagnosed, or they're diagnosed, but there's just not sufficient amount of time, or they're insufficiently managed. So the hope is that after this particular talk, that your behavior will change in your clinical practice. And one of the way we're going to try to enable your practice behavior is I am going to give you a tool that I'm going to show you in a second. On this talk today, I have a teammate, and it's Lieutenant Nicholas Kruger, who is a medical student about to graduate this summer, and he is hoping to train as a psychiatrist and internist as well with us here at Walter Reed. What we'll do is go through our slides, and then at the end, I will try to come up with questions that you in the audience might have, and we'll have some of a discussion. We'll share our email addresses with you, and you're welcome to contact us. Finally, one of the other pieces, if you're watching this on your smart devices, one of the things I would recommend is watching it on a computer. At one point, I'm going to give you a link, and I'm going to ask you to download a tool, which is a PDF document. And that document or that tool only works if you're on a desktop computer. So with that, we'll begin our topic today, and I'm going to pass it on to Second Lieutenant Kruger to take it from here.
Thank you, sir. As you said, my name is Second Lieutenant Nicholas Krieger. I'm a fourth-year medical student here at the Medical College of Wisconsin. To start off today, we are going to review the learning outcomes. So the learning outcomes for this presentation today will be that you will be able to rapidly diagnose anxiety or depression in your primary care setting. You should be able to select the most appropriate psychotropic medication to manage anxiety or depression, as well as you should be able to demonstrate follow-up management of a patient with anxiety or depression, and lastly, be able to demonstrate the use of the psychotropic decision tool when managing a patient with depression or anxiety. As far as disclosures, the views expressed in this activity are those of Dr. Amin and I, and do not reflect the official opinion or policy of the Department of Army, Department of Defense, or U.S. government. We have no conflicts of interest to disclose, and we will be, within the tool, there will be use of off-label uses of the medications that we will be presenting on. And then we have no financial or non-financial interests to disclose. So starting off as sort of an introduction to the mental health care needs of our country, as I'm sure most of you are aware, depression and anxiety are very highly prevalent conditions. At any given time, it is estimated that 7 to 10% of the population, they're estimated to have depression. And of this large population of people, up to 55% receive treatment, and as low as 27% of them are actually receiving the adequate treatment, which we see as one of the biggest issues here. It really turns out to be a major ethical responsibility for all care providers, especially in primary care. And again, as I'm sure most of the audience is aware of, there's a very large mental health provider shortage in our country. It is estimated that the shortage of psychiatrists is around 2,800, and only expected to increase going forward. It is our hope through tools like this presentation today that we can help reduce this gap by empowering the primary care providers to basically help. So why should we care that our primary care colleagues can do this basic psychiatric care? Most discreetly within the Army, it is policy, so 18-46 MedCom policy, primary care behavioral health integration. Primary care managers will be trained to recognize and manage depression, anxiety, PTSD, and alcohol problems. But more fundamentally, it is relevant to the overall mission. Psychiatric related issues represented 10% of all aeromedical evacuations from OEF, OIF, and OND. And it is the first and fourth leading cause of evacuation for female and male service members. So there are substantial patient-specific barriers with managing mental health in primary care. We first talk about chronic physical comorbidity, which decreases the odds that physicians and untreated patients discuss depression as possible diagnosis. Other patient-specific barriers include new problems that will arise in clinic, age of the patient, stigma surrounding mental health care in general, as well as racial ethnic disparities and overall poor adherence to recommendations. So going on to the provider-specific barriers that we hope to address with this presentation, there seems to be an overall low confidence in treating mental illness in the primary care setting, which strongly predicts a primary care provider's willingness to assess and treat suicidal patients. And I guess fundamentally with this issue, there's a poor or inadequate training to our primary care providers in order to provide this care. Within internal medicine and primary care, or 3-year primary care and internal medicine programs, there's about 99 hours allocated towards this sort of care. And up to 63% of trainees indicated the need for more psychiatric training in their residency. Other barriers, of course, are time constraints in the primary care setting, overall lack of interest in mental health, especially most of these providers do not go into their intended field looking towards treating psychiatric illness. And also just an overall amongst providers, it's a lower satisfaction with psychiatric referrals to their clinic. And then just to review as a preface for the next slide on the significance of effect size. The effect size examples here stated on the left, an effect size of 1 when looking at treatment differences in a patient population signifies standard deviation changes within this bell-shaped curve representation of, for example, patients who across the country are screened with the PHQ-9, which is a depression screening tool. They tend to fall some patients will screen towards the very low side to 0 and sometimes all the way up to 20 in this bell-shaped curve. When it's shifted with intervention, can be seen as an effect size. And an effect size, for example, of 0.8 is considered a large effect size in psychological and medical research. 0.5 is seen as a moderate effect size, and 0.2 is seen as a small effect size. And on this next slide, the main takeaway from this graphic here is on the right. On the right, you see these psychiatric drugs and the efficacy seen in the patient population that they are prescribed to. And on the left, you see more general medicine drugs to include things like PPIs or cardiovascular drugs to treat CAD and other more commonly prescribed drugs in primary care. As you can see here, the median average efficacy for these drugs mirrors that of psychiatric drugs, which is, this graphic is a good representation of why we should place more confidence in treating psychiatric issues with psychotropic medications in the primary care setting. Common clinical concerns with approaching psychotropic medications in primary care is underdosing. Are we prescribing the correct dose and regimen for our patients? Inappropriate duration of treatment, lack of follow-up. What exactly follow-up do our patients need for these psychotropic medication prescriptions? And also subpar mannerisms, to include attempting to convince patients that life was not that bad, engaging in the superficial chit chat rather than probing the issue of suicide, and just a subpar identification and assessment of the level of suicidality within patients. When screening for anxiety and depression, we can approach these with pretty rapid diagnostic tools to include the GAD-2 for anxiety, and if positive, this goes on to the GAD-7. For depression, we commonly use the PHQ-9, which, if positive, will reflex to the PHQ-9. And we'll discuss using the GAD-7 and PHQ-9 scores as outcome measures in the second half of this presentation. And then just a last comment on these screening tools, tips specifically for military providers. It is vitally important for our service members to always rule out adjustment disorder before placing a medically boarded condition such as major depressive disorder on these service members. This can greatly impact how a service member is separated from the service. If these patients do have an adjustment disorder and their acute psychiatric needs are because of service, it is important to facilitate a smooth and as quick as possible exit from that overlying exacerbating factor. And then this figure here just shows what the PHQ-2 screening tool looks like. 2 questions are asked here, which I'm sure most of us have seen in clinic. And below, we can see what these scores correlate to with the probability of major depression. And as you can see, as the PHQ-2 score goes from 1 to 6, the percentage probability of diagnosing major depressive disorder, or really any other depressive disorder, drastically increases. And this shows the good reliability and the need to use these screening tools more frequently. And then going on to screening for anxiety disorders with the GAD-2, you can see here, most notably for generalized anxiety disorder, with a cutoff score of 3, the GAD-2 score has a pretty high sensitivity and specificity at 86 and 83% respectively, and as well as you can see down the list, panic disorder, social anxiety disorder, and PTSD show pretty promising results as well, further underlying the need to use these, especially in our military medicine clinics. And then now I will hand it over to Dr. Amin for the second half of the presentation. Thank you.
Thank you, Nick. So now that we have kind of gone through some of the background, given that you are watching this, you probably don't need a whole lot of convincing, but what we were trying to do with this topic so far is try to illustrate that one, mental illness is very prevalent. 2, there's not enough psychiatrists to take care of it, and therefore primary care have to step in. However, primary care providers are not getting sufficiently trained in it. They lack confidence, and when they do manage patients, there might be some room for improvement. For example, patients may not be on appropriate dosing, so patients might be underdosed and or not treated at all. There's also lack of appropriate follow-up, and then we also briefly discussed the concern with inappropriate assessment for safety, and we kind of gave you some of the examples with the mannerisms. We also try to address this issue of, well, psychiatric meds aren't as effective, so why even bother? And we try to illustrate the effect sizes of psychiatric medications compared to primary care medications, and essentially the effect size is coalescing around the same 0.3 to 0.4 effect size. And so with that, now the question is, well, you might say, how can I manage depression when my patient has 5 other issues and I have 15, 20 minutes with them that I have to manage? And that is completely, a true reality and a true barrier. And so what we want to do is kind of help you do it rapidly and effectively. And so let's share with you an approach that we have used to address this challenge. So we conducted some training with about 30 or so primary care providers, physician assistants, and physicians. And we had similar training products such as, these slides that you're getting, but we also used PDF-based decision tool. We then subsequently assessed these providers' sense of confidence in treating and whether or not that changed pre versus post training. And we also looked at it 6 months later. We surveyed some of these providers. And so I want to just share that with you. These are some of the demographics data for the people who participated in the training. And their confidence level to select an optimal psychotropic medication for depression or anxiety improved. Their knowledge and skill to change the dose or the medication improved, and then knowledge and skill to prescribe behavioral health improved. So in this particular training, we had also gone into behavioral health training as well. The confidence to titrate psychotropic did not change in our assessment of this curriculum. And then at 6 months, likelihood to adjust medication dose, likelihood to start a medication for anxiety or depression, and then those two had significantly improved. Referring a patient for anxiety or depression had gone down, suggesting that they were more likely to manage these patients in the primary care setting, but it didn't meet the significance level of P of less than 0.05. So now I'm going to pause here for a second. What I'm going to have you do is download this tool. And so you can either do that by taking a picture of this bar graph or this QR code with your camera, but I would really want you to access this and download this to your desktop computer or your laptop, either Windows or Apple laptop. Okay, so if you were to go to that link, what you're going to download is this tool. And this tool is going to hopefully enable you to quickly go through a patient. Lieutenant Kruger had discussed with you universal screening. So ideally in your clinic, you should be screening everybody with a GAT2 and and a PHQ-2. They have pretty decent sensitivity, so it'll help you rule out those without. And then those that are positive on that, we recommend that you then have them take the PHQ-9 or the GAD-7 to truly kind of get the grasp of severity of their depressive or their anxiety symptom. Now, someone being positive on PHQ-9 or GAD-7 do not necessarily mean that they have a clinical, major depressive disorder or generalized anxiety disorder or some other anxiety disorder from DSM-5. It just means that they're in distress. And so then you'll have to, do your diagnostic assessment and make sure that they indeed have that. And in the Army or in the military, we like to, focus on making sure that they don't have adjustment disorder, as Lieutenant Kruger had mentioned. And we want to focus on, operating with an acute adjustment disorder diagnoses, and if it still persists, and if a case could be made for DSM-5, other DSM-5 diagnoses like depression or anxiety, then we would go with that. And so so let's say once you have a patient with depression or anxiety, then ideally you'd want to pull up this tool and you would click on this to begin. And what this does is there are hyperlinks within the document, so it'll just jump. There are 33 slides in this document, and it'll just jump to the right slide, essentially. So we're going to click here to begin. This is my disclaimer. Essentially, just use this at your own risk. It's not meant to be the authority on management of psychiatric condition. It's really meant to just help you. So, so let's begin with the first encounter. So you're going to start a new medication, and then we're going to subsequently use this in a bit. The home button here should enable you to jump back to the beginning of the slides at any time. So we're going to go ahead, and so we have a new patient, and we think they have depression, let's say. So we're going to click on this. And now you're going to be given two options. So if you know exactly what medication you want, you can click on pick the medication yourself, and then the medications listed here are just the ones that are on the DoD formulary at the moment when I created this tool. And so it's limited to that, but it covers significant number of medications, or help you pick a medication. So I'm going to go with this first, and then I'll show you this as well. So here, what we do in psychiatry is, a lot of meta-analyses done show that SSRIs, all of them are no different than the rest. So they're equivalent, and then SSRIs and SNRIs are equivalent when it comes to depression. And so there's no difference. So the approach that we take is, how can we address maybe a couple of different symptoms or a couple of different issues based on the side effect profile or the positive effect profile of a particular medication. So for example, we have a patient with depression and insomnia, let's say. And so you would then click on, okay, the patient has depression or anxiety, plus they have insomnia. So you're going to click on the insomnia, and it'll give you a list of medication. How about a patient is also a smoker, and they might be interested in stopping smoking? Or the patient has chronic pain or fibromyalgia, let's say. Or the patient is a geriatric patient, which is, when you're more likely to face polypharmacy. And so you may want to go with a medication that has the least drug-to-drug interactions, let's say. And so of these, you can play around with the tool, but let's just click on the polypharmacy piece. I'm going to click on this, and it will jump to these medications that have the least amount of concerns when it comes to drug-to-drug interaction. And all of these medications are something that you can click on. And so for whatever reason, you might decide that you're going to go with escitalopram. And so you're going to click on the escitalopram, and it's going to give you a slide that is dedicated to escitalopram. And the common drug name or the brand name in the US is Lexapro. So here it outlines some of the common side effects. And then here, one of the things that we want to address with this is that whole issue of underdosing. So someone gets started on 5 milligrams of Lexapro or escitalopram, and then they stay on that forever and ever, and they continue to have symptoms, but they're not following up. And then 6 months later, they're still getting the same refills. So here, what this does is it enables the patient to go ahead and auto titrate their medication. Typically, with escitalopram in my practice, I give them a 10 milligram pill, and on the label I usually say take 1 1/2 pill, but I give them this sheet. And so then they start off with just 5 milligram, and if they don't have one, I ask them to get a pill splitter or a pill cutter to make it easier. But they start off with 5 milligram, and I like to start really, really low because I don't want the patient to give up on a medication because of usually the GI side effects. So start low, and there's really no rush. And so 5 milligram, then week 2, they bump it up to 10 milligram. Week 3, they bump it up to 3 milligrams. So in this case here, the patient is given 10 milligram and 5 milligram pills, or 5 milligram pills, sorry. So they're taking 2 tablets and 3 tablets. And once they're at the target dose, then you can give them a larger dose, essentially. So here I am usually shooting for 75% of the FDA upper limit dose. So upper limit dose in the US for this is 20 milligrams. So I'm shooting for 15 milligrams by the time they come back and see me, and then follow up in about 3 to 4 weeks. If that is not realistic, at least 6 to 8 weeks. And if you have the right systems in your clinic, you may ask your nurse or other healthcare extenders to even do a phone call and just check in with the patient, make sure that they're tolerating the medication well. So now you have started the patient on escitalopram, and the patient follows up. So let's go ahead and look at the follow-up encounter. So the patient follows up now, and they report to you that they feel like their depression is improving, and it's about 50% better. Okay, so here are some rules now. If the patient comes back and they say, "Doc, I can't really tolerate the medication at all," then you don't really have a choice but to switch them. Or in some cases, you might reduce the dose further by 25%, but most often you're just going to have to switch the patient. Now, there are two types of responses that a patient could have. They could have partial response or a complete response. And so if they have partial response, what that means is that they have 25 to 50% reduction in their symptoms. And we're going to talk more about that in a second. You can actually use PHQ-9 scores or GAD-7 scores, depending on if you're treating depression or anxiety, to judge whether or not someone is having partial response or full response, or lack of response. So let's talk about lack of partial response, which is less than 25% reduction in the symptoms. And it really, it meets that definition if the patient has been on an appropriate dosing and appropriate duration. This is why I try to shoot for that 75%, because then I can say, yeah, I mean, the patient was on a pretty good dose of escitalopram, 15 milligram, and they still haven't had any response at all. In that case, go ahead and just switch to a different drug and different class. So escitalopram is an SSRI, so I might go with an venlafaxine because we're still concerned about the drug-to-drug interaction. Venlafaxine was one of the medications with least amount of drug-to-drug interaction, so I would go with venlafaxine. So we'd switch that. If the patient had only partial response, then you may want to just go ahead and increase to the highest FDA dose and then have them follow up in another 4 to 6 weeks. And then, you would go from here. If the patient says, yeah, I've had about half decrease in my symptoms, or you're using the PHQ-9 or PHQ or GAD-7, then that is considered full response. So you'd want to continue the current medication for 6 to 12 months, and then initially follow up monthly for 3 months, and then quarterly if you can. Just to check in with them, make sure everything is going okay, and that they have not dropped below this response. Sometimes patients might initially respond, but then other circumstances happen in their life, stressors increase, and they may end up going back and have a relapse of their symptoms. Remission is when someone has been without symptoms for 6 to 9 months. And so when the remission happens, then you're going to have to consider, okay, are you going to discontinue the medication, or are you going to do maintenance therapy? So typically, for people who have had recurrent symptoms or recurrent episodes of depression, or usually patients with anxiety disorders, usually need lifelong therapy. And so I usually just drop it by 50%. So if they're on escitalopram 20 milligrams, I would say, let's just go ahead and keep you on at least 10 milligrams. And there are a lot of studies that show that if you continue maintenance therapy, you significantly reduce the chances of relapse. There are long-term consequences. So there's some association with osteopenia if you stay on SSRIs for a really long time. But outside that, there's really not a whole lot of significant issues with it other than the cost, perhaps, or discontinuation. So here I recommend over 1 month titration. There's even some new data now that you should discontinue people over a 3-month period even. So the slower, the better. And so you'll just have to create a titration for them and say, okay, I would like you to go down on your escitalopram by 5 milligram every 2 weeks, for example. And so depending on what dose they are, they can wean off over that period. So this is an approach to patient following up. Now let's go back. And so we have talked about follow-up encounter and what to do, and we talked about initial encounter. And then here I had earlier gone to the help me pick a medication for my patients. So you can, click on that, and then you have a bunch of other options here that would help you pick a medication that's going to help you address a couple of things for the patient. Now let me show you the initial encounter and then pick a medication from the list yourself. And these are the medications that are in this tool. So I think it has SSRIs, SNRIs, just a couple of comments. So for pregnancy or breastfeeding, lactating mothers, sertraline is the primary, and then escitalopram is the secondary. A tertiary option is venlafaxine. Do not use paroxetine in pregnancy. So that would be sort of a not to use, and then you have a bunch of other options. Fluoxetine used to be something that was recommended for this pregnant population or women that are trying to become pregnant, but this is no longer recommended. So sertraline is really the first choice, first line of medication. And all of these you can click on. So let's show you the sertraline one, and it shows you what to do. And so in this case, they have gotten a 25 milligram pill, and then up to 6 tablets. So that obviously becomes pretty burdensome. So give them sufficient amount where they follow up, or you can give them larger pills that they can split. Okay, so this was an introduction to the psychotropic tool, and now we'll switch back to the slideshow. Okay, so back to this slide. So in case you did not download the tool, you can go ahead and pause here and use this link. So moving on, a couple of things here that I want to address. So this is assessing the severity of someone's depression. And you can use the same cutoffs for GAD-7, for example. So mild depression is a PHQ-9 score of about 10 to 14. Moderate is 15 to 19, and severe is greater than 20. Again, I want to emphasize PHQ-9 score being high does not mean someone has major depressive disorder. It just means they have distress. It may be due to an adjustment disorder or depression, for example. So, so for mild depression, you can offer the patient, hey, if you want to go talk to someone, I can refer you. You can refer the patient for counseling. You can kind of do a watchful waiting and see if they get better, or you could even, ask them to do simple things like maybe exercise, aerobic exercise, 30 minutes a day, etc. However, you may also offer a patient an antidepressant, and so these mild patients with mild depression should really be the realm of the primary care provider. Now, with moderate depression, you have the option of monotherapy or monotherapy with antidepressant or psychotherapy or combination. So a lot of patients may not have the ability to schedule, time constraints, and so on, and they may elect to do an antidepressant, and that's completely fine. And so you are welcome to do that. But if they say, you know, I want to do both, and so then you'll obviously be sharing that patient with a psychotherapist. Another time to consider sharing someone with moderate depression is especially if they have any kind of suicidal thoughts. And you know, if someone has suicidal thoughts but they don't have any intent or plan, they're not rehearsing method, etc., then, you know, obviously it doesn't qualify for acute hospitalization, but you may want to get them into a behavioral health system, i.e. with a therapist who might be able to see the patient on weekly or bi-weekly basis. So, and then finally, severe disease, you want to prioritize an antidepressant. There's some evidence that antidepressant upfront may be better. Often these patients with severe depression have cognitive issues and they may not be the best candidate for psychotherapy anyway. But ideally, they end up with both, and you definitely want to share someone with severe depression with a therapist. So you want to refer them to psychotherapy or, you know, do a behavioral health referral. You know, try the first two medications, and if they're not effective, then refer them to a psychiatrist or psychiatric nurse practitioner, someone that specializes in pharmacotherapy. Another time to share and refer people to behavioral health is someone that have co-occurring behavioral health conditions, so personality disorders, substance use disorders, etc., or PTSD. PTSD has a lot of specific and unique type of psychotherapies, such as prolonged exposure, cognitive processing therapy, etc. And so you definitely want to refer them, but you may continue to prescribe the patient their SSRI or SNRI. So that's essentially an approach of when to refer someone to behavioral health. So if they're suicidal, you should refer them to behavioral health. If they need psychotherapy, refer them to behavioral health. If they have comorbid substance use disorder, personality disorder, or other significant psychosocial issues, then refer them to behavioral health because they have longer appointments and more resources. So just a couple of more comments on the psychotropic decision tool. So the way when I made this is it's meant for you to have on your desktop as you're seeing patients, have it open, and then you print out that specific medication page and you just hand it over to that patient, and then they are discharged, you know, with the right amount of medications for it to last them sufficiently. And then by the time you see them again, let's say you put them on sertraline, they'll be on 150 milligram dose when they show up. So there's going to be no question that they are on the appropriate and therapeutic dose of sertraline. And by the time they follow up, you know, we have that whole rule about giving someone 4 to 6 weeks. So when they show back up again, you will then assess the follow-up encounter. And as I shared this slide with you from the tool, you would want to know whether they had, you know, partial response, full response, no response at all, or a lack of partial response, less than 25%. And so if you in your clinic, if you use PHQ-9 or GAD-7, you can actually assess whether or not the patient is, so that's a more objective, quantifiable way of knowing whether or not the patient's scores are dropping. In my practice, I give greater weight to their own self-perception. So I ask them, okay, what % do you think your symptoms are better since I saw you 2 months ago or 6 weeks ago? Give me a number. And then they usually, because ultimately what matters is sort of their overall self-assessment. And if they say, doc, I am, 60, 70% better, then you just keep them on that medication. You continue to follow them closely for the next 2 visits. And then after that, you can follow up with them on quarterly basis. And depending on if they're on maintenance therapy, you can see them every 6 months even. But follow-up is still important. And you want to make sure. One other piece to recommend to patients is make sure you let them know that please do not stop your medications suddenly, i.e. cold turkey, because of the issues with SSRI or SNRI, discontinuation syndrome. And it's worse with medications, the SNRIs. It tends to be worse, and the worst culprit is duloxetine. So patients tend to have severe discontinuation type of symptoms, i.e. zapping sensations and things like that. And people can have panic attacks and even become suicidal. Can be that severe. So with that, I hope that you found this this topic useful. It's intended for you to change your clinical practice. So I would personally love feedback. If you're using the tool and it's helping you, then please shoot me an email. If you're using the tool and you think it could be improved upon, also give me feedback. And then finally, here's some instructions. If you're watching this for the AMSIS 2020 annual virtual meeting, then use this link to receive continuous education credits. With that, I'll ask Lieutenant Kruger if he has any additional comments. Otherwise, we'll end the presentation.
Thank you, sir. I would just like to add that thank you for tuning in and listening to our presentation, and I hope this does change how you practice and impact your patient population going forward. Thank you all very much.
Thank you. Bye-bye.